The paper I'm going to present is about the prevalence and severity of periodontal disease in mainland China. The data were obtained from the 4th National Oral Health Survey, which was a cross-sectional survey supported by 2 other Chinese organizations. The first one was the Public Science and Technology Research Fund project, and the second one was the Peking University School and Hospital of Stomatology. Stomatology is a branch of the medical science dealing with the mouth and its disorder. Peking University is a university located in Beijing and is been established in 1941. It's quite famous internationally, and also is got education for oral health as well as combination of education in implantology, prosthodontics, periodontology, oral and maxillofacial surgeries. The aim of this paper was to evaluate the periodontal status of 3 adult age groups in mainland China using data from the 4th National Oral Health Survey. The material being used is 3 different age groups, which the first group was 35 to 44 years old people, second group was 55 to 64 years old people, and the third group was 65 to 74 years old people. The question also being used to obtain the characteristic of the participants, such as the demographic characteristic, which was included age, gender, regions, and socio-economic characteristic, which was level of education and income, personal habit, which only smoking status being considered, and dental history and health attitude. The periodontal status also being assessed using a standardized 2018 classification scheme, which is quite similar to the BSP being used in the UK. To extract periodontal data, 4 parameters being assessed. First one was the presence or absence of the calculus. Second one was periodontal pocket depth. Third one was clinical attachment loss, and the last one was bleeding on probing. Also, community periodontal index probe being used. As the table shows, for calculus being detected visually, supragingivally, and or detected subgingivally by the aim of the probe, different numbers being given. So 0 for the absence of the calculus, 1 for the presence of calculus, 9 when the tooth is excluded, and X for tooth missing. Different numbers were allocated to periodontal pocket depth, 0 for 1 3 mm, 1 for 4 to 5 mm, 2 when the periodontal pocket depth is equal to 6 mm or higher, 9 for tooth excluded, and X for tooth missing. Clinical attachment loss also being assessed by its distance from cemento enamel junction to the bottom of the periodontal pocket. 0 for the when the clinical attachment is lost between 1 to 3 mm, 1 when the clinical attachment lost is 4 to 5 mm, 2 when the clinical attachment was 6 to 8 mm, 3 when the clinical attachment lost was 9 to 11 mm, 4 when the clinical attachment was equal to 12 mm or higher, 9 again for tooth excluded, and X for tooth missing. Classification of periodontal and pre-implant disease being used according to the standardized 2018 scheme, which was quite similar to the BSP being used in the UK, was for periodontal healthy when bleeding on probing was less than 10% and periodontal pocket depth was equal to 3 mm or less than 3 mm. Gingivitis for when bleeding on probing was equal to 10% or higher than 10%, and periodontal pocket depth was equal to 3 mm or higher than 3 mm. For periodontitis is also there were 4 stages, which is being shown in next slide. Also, the number of the missing teeth were considered, but the reason why the teeth being missed did not take into the account, so it could be for any reason like caries, trauma, as well as periodontal disease. Periodontitis stage was 1 if the clinical attachment loss was between 1 to 2 mm, and there was 2 when the clinical attachment loss was 3 to 4 mm, and also there was no missing teeth in stage 1 and 2 periodontitis. In stage 3 periodontitis, the clinical attachment loss was equal to 5 mm or less than 5 mm, while the number of the teeth missing was less than 4, and periodontitis categorized in stage 4 when the clinical attachment loss was more than 5 mm and the number of the teeth being missed was more than 5. And also periodontitis being called localized when less than 30% of the teeth being involved, or called generalized when 30% or more than 30% of the teeth being engaged. According to the data from the paper, the number of the participants was 13,459 people, which was quite a good number of the people participated in this paper. There was no significant difference between the number of the male and females, and also the percentage of the male and female being in this survey were almost the same. The number of the people living in urban area was 50.7%, while the number of the people living in a rural area was 49.3%, which in this point is also pretty the same. The number of the non-smoker in this survey was quite high, was 63.6%, while the number of the former smoker was quite low, was 10.1%, and then the number of the current smokers was 26.4%. The frequency of the severe periodontitis, stage 3 and 4, was quite high in second age group, which was 55 to 64 years old, and also in third group, which was 65 to 74 years old, compared to the first age group, which was 35 to 44 years old. The first group had the frequency of the severe periodontitis was only 10%, while the severe of the periodontitis in second and third group was 37 and 43 respectively. The severity of periodontal was greater in elder people and also people with a current and former smoking status. There was no significant difference between people living in a rural area compared to people living in urban regions. So it means the socio-economic status had no effect on periodontal severity, and only number of the edentulous people in rural area was higher than urban area, but the reason why the teeth being missed not being taken into the account. So it could be anything like caries, trauma, as well as periodontal disease. And there was no significant difference between male and female in severity of the periodontal disease. And also there was no improvement in periodontal status from 10 years ago in mainland. For example, almost everyone, which was 94.8 to 98.3% of people never ever clean between their teeth, or only minority of people received hygiene cleaning a year ago, which was only 2.2 to 7.9%. So China has got a great population which is 1/5 of the global population, and so China has got an aging society. It is quite acceptable and to expect that the periodontal status became worse if not effective policies being taken to address the problem. For example, educating people about the periodontal disease and oral health condition, and also training more dental professionals to take a preventative treatment. This study also has some drawbacks. One of them is only the most severe site indentation being recorded, although all sites of dentation being assessed. So there is a possibility of overestimating the result. For example, healthy periodontal being categorized as gingivitis. Vacation involvement, tooth mobility, and malocclusion had not been assessed. So there is a possibility that stage 3 and 4 periodontitis being underestimated, and also a stage 4 periodontitis being overrated by accounting missing tooth for other reasons. The severity of periodontitis was assessed only by smoking status and age, so other risk factors such as medication and systemic conditions not being taken into the account. X-rays not being used for assessing the stage of periodontitis. But it could be relevant to current dental practices according to this paper. As paper mentioned, smoking was the main contributing factor for periodontal disease, and also, as we know, smoking is one of the main risk factors for all systemic disease. So dental professional need to allocate time for a smoking cessation at each appointment of patients, and also as a part of multidisciplinary team to corresponding with other health professionals to providing tailored oral health advices and treatment for each individual. And also dental professional needs to take a preventative approach by educating patients at each dental appointment.